Welcome everyone to our Thursday webinar series. We are glad that you are with us today. I'm going to wait just a few minutes and make sure everyone gets connected. My name is Lourdes, Director of Patient Services with the Cholangiocarcinoma Foundation, and we are always glad to have you and be able to share information with you all. Today's speaker, his name is Dean Belcher, and he is currently working as a trainee advanced clinical practitioner at the Christie Hospital in Manchester, England, and currently undertaking a master's in advanced practice at the University of Salford. His previous roles include HPB clinical trial nurse, chemotherapy nurse, and charge nurse on an acute medical ward. I want to just remind everyone to please put any questions that you might have in the Q&A or the chat, and to please make them general in nature pertaining to this topic. Dean, I will hand it over to you.
Thank you. So yes, hi everybody. My name is Dean and I'm currently working in the Christie Hospital in Manchester. And I've chosen to talk to you today about clinical trials and try to demystify some of the misinformation that people or misconceptions that people and patients have surrounding clinical trials. Before I start, I thought I'd just tell you a little bit more about me. Lourdes has already given me a great introduction, so I'll just sort of whiz through this part. So my nursing career, I guess, began in 2007 when I was 20, and I got a job in my local hospital as a healthcare assistant on the acute medical unit. I then did my nurse training at the University of Chester. I graduated in 2012. Once I graduated, I stayed in my local hospital for a total of 5 years. I was a staff nurse, and then I moved on to become a charge nurse for a year. And then I fancied a change. I took an opportunity to move to Manchester, which was the big city close to my town. And I was lucky enough to get a job on the chemotherapy unit at the Christie Hospital, based in South Manchester. After 2 years, I decided to specialise and found that HPB in particular was my kind of area of interest. So I applied for a clinical research nurse job in the HPB team and the neuroendocrine team. I spent 4 years there working on many clinical trials. I managed to do my nurse prescribing whilst I was in the team also. And then as of September last year, I got the opportunity to undertake a master's in advanced practice, and my current role is a trainee advanced clinical practitioner, which I understand is the same as a nurse practitioner over in the United States, where an advanced clinical practitioner or an ACP is just an autonomous clinician who can review, diagnose, and treat patients without the supervision of a doctor. And for anybody that doesn't know, the Christie is the largest single-site cancer hospital in Europe. We serve a population of 3.2 million patients and treat around 60,000 patients per year. And we are accredited, the first UK accredited comprehensive cancer centre. And we are ranked first as the most technologically advanced cancer centre outside of North America. So the aims and objectives of this presentation, there's quite a lot to get through, so do forgive me if it seems like I'm rushing. Please ask questions at the end if you want me to clarify anything or cover anything again. So we'll cover what clinical trials are and why they're needed, some of the common terminology you might hear if you take part in clinical trials, some of the people you may meet, and some of the people working in the background, the types of clinical trials, phases of clinical trials. A common question that comes up a lot is placebo, so I'll talk quickly about placebos. And then we'll talk about approval and licensing, eligibility, informed consent, the screening period, monitoring, and finding clinical trials. And then there'll be an option at the end for questions. There are some QR codes throughout the presentation just to help you find resources. So if you get your phones at the ready and grab yourself a nice cup of tea, and we'll begin. So first of all, I just want to get a feel of who's on the call. This is the first time I've done anything like this, so I'd just like to know sort of who are patients, who are caregivers, who are healthcare professionals. So I'll just give you a few seconds to have a look at that. Hopefully this works. Ah, yes, there we go. It's a good mix of people. Okay, interested to know what the others are. Okay, so if we move on, and then I'd just like to get a sort of a base of your current knowledge of clinical trials, how you feel your current knowledge is, and hopefully I can improve on that throughout this presentation. Okay, excellent. So there is room for improvement. Hopefully I can nudge you all up a couple of scores by the end. So what are clinical trials? So they are research studies that are conducted in a specific group of patients that aim to answer a specific question. They look at the efficacy of drugs, side effects, and compare it with the standard of care treatments. Clinical trials are conducted using an international set of standards, and these standards are known as good clinical practice. Anybody involved in clinical trials from a healthcare professional point of view has to be trained to good clinical practice and has to follow these guidelines um, throughout the clinical trial from very start to the very beginning to the very end. All clinical trials undergo ethical approval. The Institutional Review Board and Research Ethics Committee, we need to ensure that clinical trials are ethical because there are human beings and people involved. And clinical trials are the safest and fastest way to improve health outcomes. Why do we need them? So we need clinical trials to advance care. We need them to develop new drugs. We may want to look at different combinations of drugs, drugs that are already used in other disease groups or given in a different order. Maybe drugs that are, for example, currently given second line, could they work better as first line treatments? We can look at different surgical procedures and devices that may work, implants that we can do that deliver local therapy over a longer period of time. We can also look at blood, so we can look at biomarkers in the blood, so we can look at specific mutations, ctDNA. ctDNA is just circulating tumor DNA, and that's DNA that's been excreted by the cancer and in the bloodstream. And we can also look at different ways of tracking the cancer, maybe screening with different imaging at different time points. Maybe the frequency could be extended, or maybe frequency needs to be shorter so we can pick up any changes sooner. And obviously, we want to improve patient outcomes. And by patient outcomes, I mean progression-free survival, overall survival, and of course, quality of life. One of the most important things for us as clinicians is to ensure that obviously patients live longer, but we want to ensure that they live longer and are well, and that they can do the things they enjoy doing, their quality of life remains good. And that's one of our main goals. And clinical trials aim to determine if a new test procedure or treatment is safe and effective. Some of the common terms that you may hear in clinical trials. So we have adverse events. Adverse events are any unrelated event that occurs usually from signing the consent form to end of study. And adverse events can be related or unrelated to the drug or the intervention or the study. Serious adverse events are adverse events that are serious, and by serious we mean usually mean admission to hospital, prolongation of admission, or causing severe disability. Informed consent and eligibility, I'll touch on a little bit later, but informed consent in a nutshell is a consent that has been signed with the patient, but once the patient has read and understood the risks versus the benefits. Eligibility is just the suitability of that participant to the clinical trial. Quality of life, obviously, quality of life is how well a patient is living through their treatment, but also within a clinical trial context, we have quality of life questionnaires, and that's how we can track how treatments affect a patient's quality of life. Screening period. This is a period post consent but prior to starting treatment. Screening period will be discussed later in the presentation. Um, Baseline, we usually use this term to refer to the baseline assessments. For example, baseline bloods to ensure that liver function is safe to go ahead, the renal function safe to go ahead, a baseline imaging to ensure that we've got a most current and up-to-date snapshot of the disease so that we can track it periodically throughout the clinical trial. Placebo, I'll touch on a little bit later. The control arm is the non-experimental arm of the study. Inclusion exclusion criteria is a set of criteria that each patient must meet with regards to inclusion. And if a patient meets any of the exclusion criteria, then they are excluded from the study. And this is usually down to safety of the intervention. Enrollment, this is usually a term used once a patient has passed the inclusion exclusion criteria, has been registered onto the trial, and you are assigned a clinical trial ID. And randomization is the term used once a patient has been randomized to an arm of the study, and this is usually done on a computer. Some of the people you may meet during clinical trials. Principal investigator. Now, this is the doctor, usually doctor, that is responsible for all research activity for that particular clinical trial at an individual site. So, for example, at the Christie, we'll have a principal investigator. A hospital down in London will have a principal investigator. Principal investigator has overall responsibility but delegates a lot of the tasks and roles out to sub-investigators, which are doctors working alongside the principal investigator. The research nurse is usually the go-to contact for the patient. They coordinate the visits, they coordinate the assessments that are needed, they ensure that the right data is collected, and they just take the patient through the journey and make the patient's life a lot easier. Phlebotomists take the blood. Healthcare assistants vary depending on where you are in the world. Here at the Christie, the healthcare assistants that we have they basically run the clinic. So they will have a list of patients, times they're due in. They will call the patients into the clinic room. They will weigh them, take their height, do their observations, do anything else that's required for that particular visit, ECGs, urine samples. The very, very useful assistants to have. We have research practitioners, radiography staff. So these are the staff down in the radiology department that talk you through and take you through your CT scans, your MR scans, physicians assistants, nurse practitioners, and advanced clinical practitioners. All people involved, whether you meet them face to face or you just hear about them or they're working hard in the background, all work to GCP guidelines and are signed off by the principal investigator. And talking of people working hard in the background, I thought it was worth mentioning all the people that you don't get to meet that are doing a lot of work in the background. So we have the pharmacists checking that you're on the correct dose of drug, making sure there's no interactions, dispensing the drug, ensuring that the drug is made up at the correct time to save patient delays. We have the data managers who manage the data. So once we've collected all that data in clinic, we hand over that data to the data managers. They use that data, they input it into the system, they ensure it's clean data and report it back to the sponsor of the trial. clinical trials coordinators. These are people that are more involved in feasibility of a clinical trial, the setup of clinical trial coordinating, sort of from when a site is approached to set the study up, all the way to closing out and archiving a clinical trial. They work very, very hard, and they are our go-to person, and usually the sponsor's go-to person if they want to communicate to the site as well. And then we have a medical monitor. Medical monitor is a doctor, usually a doctor, a consultant who is working on the study and offers their expertise to healthcare professionals if we have any concerns regarding our patients. If, for example, our patients have some unusual adverse event or side effect or toxicity, we're not sure how to manage it, we can contact the medical monitor and they can offer their advice to us. Monitors, these are people who work for usually for the sponsor, and in the case of a monitor at the Christie, monitors come in periodically. They ensure that everybody is working to GCP guidelines. They audit the data to ensure the data is clean, accurate, and that we're following the protocol correctly, so that we can answer the research question at the end of the study. And the sponsor is the usually a pharmaceutical company or university who is funding or running the study. So there are different types of clinical trials and studies. We have interventional studies. These are the studies that have an intervention, such as a drug or multiple drugs. We have observational studies. These studies can be retrospective or prospective. So by retrospective, I means that we look back through a set of patient records. So, for example, cholangiocarcinoma patients or with IDH1 mutations on specific drugs, and we look at their outcomes, and we could compare, for example, patients on the same treatment, a group of patients that did have an IDH1 mutation versus patients that didn't have an IDH1 mutation, to see if those patients did any better, whether their outcomes were different or whether they were the same. We have randomized control trials. These trials are usually standard of care treatment versus a new combination of drugs. And they're randomized, done by a computer, double-blinded studies. These are studies that both the participant and the research team aren't aware of the treatment that the patient is allocated. And open label trials, this is when the participant and the research team are aware of the drugs that the patients are receiving. There are four main phases of clinical trials. They can get a little complicated. They have different subcategories. So I'll try to stick to the four main phases. Most phases that most of our patients come across are phase 2 and 3, but I will briefly discuss all four. So phase 1 are usually carried out in small groups, and they are slow to recruitment, usually open to a wide range of patients with different types of cancer. And usually we refer patients onto these types of trials when all other treatments have been exhausted, kind of a when there's nowhere else to go, we look at phase 1. We are looking to evaluate the safety of a drug. So we're not looking at this stage to see whether the drug is going to do anything to that specific cancer. We're looking at dose, safe doses, and the risk versus the benefits. The very, very committal. There's a lot of monitoring that goes on. We're looking at blood, so we're looking at how the drug moves through the body. We're looking at how the body uses the drug. We have to do ECGs to make sure that it doesn't affect the heart. We're checking your vital signs, so your blood pressure, your heart rate, your respiration rate, just to ensure that the physiological effects of the drug aren't toxic. And as I said, it's about looking at the dosing of the drug before we can then start looking at, okay, now we've got a safe dose of this drug. Will it work for this particular cancer? Phase 2 includes patients with the same types of cancer, but can include different types also. They are larger. and the aims are to determine if a new treatment works well enough to advance to a phase 3, which cancers that drug works best for. So if we've got, for example, cholangiocarcinoma patients, pancreatic patients, and liver patients, that drug may work better in cholangiocarcinoma patients, it may work better in pancreatic patients. And these types of trials can tell us which groups of patients they work best for. It can tell us more information about the side effects and the toxicities of the drug, and about better doses to administer. Phase 3 are large trials. They're used in multiple hospitals in multiple countries. They're usually global and can have anywhere between sort of hundreds of thousands of patients. And they're usually comparing a standard of care treatment versus a new treatment. They are mostly randomized, and they confirm the effectiveness of the treatment. More about the side effects, how the treatments affects the patient's quality of lives, and that goes back to the quality of life questionnaires. Before a drug can be approved, we need to know how that drug affects a patient's quality of life. So these questionnaires can be quite lengthy, and a lot of patients can kind of sort of get a little fed up of filling them out all the time. But it is really important that we do get them filled in at the correct time so that we can take that information forward, and hopefully get drugs approved. And we also look at the economic value as well, in this stage. And phase 4, they're conducted once a drug has been approved to be effective, it's been licensed. So we're looking at more long-term effects. So these studies can go on for years and years and years. That they're in a larger population, whereas as you'll see a little bit later, the clinical trials that we tend to in oncology, you have to be at a certain fitness level just because of the nature of the drugs. These kind of phase trials, the phase 4 trials, are be performed in people that are less fit, the more day-to-day people. So performance status 2, 3s, people with more comorbidities, other malignancies. They're just more real life and more day-to-day. Placebo is something that we get asked a lot at the Christie. Patients often worry that when there's treatment out there, why would I go into a clinical trial and be given a placebo drug? And that just simply isn't the case. It wouldn't be ethical for us to give you a placebo drug when there is a effective treatment out there. They're rarely used in oncology, and if they are, it is usually when there is no available treatment, and it is usually a new drug versus placebo when best supportive care would be the only other option. An example of when a placebo is used would be the Topaz-1 clinical trial. And for those that don't know, the Topaz-1 clinical trial, it was a first-line study for bile duct and gallbladder cancers, and that was using the standard of care chemotherapy at the time, which was cisplatin and gemcitabine. In addition, patients would receive either durvalumab or placebo. So at very minimal there, patients were receiving the standard of care chemotherapy. 50% of patients received durvalumab, and 50% of patients received the placebo. Patients are usually blinded, and that means that the patient doesn't know which they're receiving. And on the Topaz-1 clinical trial, the researchers were blinded also, so we were blinded. We didn't know which the patient was receiving. There sometimes has to be some unblinded staff at the site. For example, the pharmacist that's making the treatment, they need to know which patient is on which drug because they have to make it, but they never meet the patient, they never come into contact with the patient. And you can be unblinded in an emergency. So if we were concerned that the patient was unwell and we wanted to know whether that was related to the drug or not, there is always an emergency number we can contact to unblind and act on that as necessary. There are different approval and licensing procedures across the world. I've tried to pick out some of the most common that I feel that people will be on the call. So apologies if your country isn't listed. In the USA, it's the FDA, which is the Food and Drug Administration. In the UK, we've got the MHRA, which is the Medicines and Healthcare Products Regulatory Agency. And then once it's been passed through there, it then has to be approved by NICE. So NICE will make it available on the NHS, the National Health Service. And this can take quite a long time, which is quite frustrating for us in the UK when everyone else around the world is getting treatments a lot sooner. In Ireland, we have the EMA, which is the European Medicines Agency, and then they have their own health regulatory authority also. And in Australia, they have the Therapeutic Goods Administration, the TGA. So eligibility for clinical trials, there's a QR code there. On the next slide, there will be a picture of this. So if you don't have a phone on you, don't worry about it. But the eligibility that we tend to come across most commonly, we look at patients' type of cancer, the stage of cancer, treatment line. So is it first line, second line, is it adjuvant? Patient's age, and this usually refers to adults, so above 18. There, every now and again, there can be an age limit. This is usually around 75, but they're not that common. It's usually just above 18 years and over. And then fitness levels. So this is what the QR code will show you. So we tend to use two different scales when we're assessing a patient's fitness. We have the ECOG performance status and we have the Konofsky performance status. So if we look at the left-hand side of the table, we have the ECOG. Generally, clinical trials for oncology patients require ECOG performance status of 0 to 1. Some do offer performance status 2, and usually it is the ECOG that we tend to use in the UK. I'm not sure whether across sort of the rest of the world and in America you use the Konofsky very often. I've seen it in a couple of the trials in the UK, but if we look at 0, for example, this is the sort of pre-treatment level fitness, fully active, able to carry all your pre-disease performance without restriction, usually able to go to work, not fatigued. ECOG performance status 1, you'd be restricted in your physical activity, but still able to carry out light housework, office work, sedentary kind of lifestyle, and fatigue that is relieved by rest. And then when we get into the kind of the lower, well, the higher numbers, I guess, ambulatory and capable of all self-care, but unable to carry out any work activities up and about for more than 50% of the waking hours. This can be a bit tricky to score people sometimes between 1 and 2. We kind of have to do a lot of digging. But these are but when we assess your fitness and we're trying to work out will you be able to tolerate this treatment, this is what we're looking at, and this is available online for you to look at in your own time. And then if we go on to informed consent, so informed consent is a ethical and it's a legal obligation. It's only accepted if a patient has received all possible and relevant information regarding treatment options. And this is where the informed comes from. Patients need to be aware of the risks and the benefits of treatment or no treatment. No treatment is also an option. The information should be accessible. So, for example, in Manchester, we have a mixed range of people from all over the world, as I'm sure you do across in the USA. I'm sure there's a lot of Spanish-speaking patients. So this information should be accessible in different languages, Braille, large print, so that we are not excluding patients or discriminating patients based on these kind of factors. Consent is completely voluntary and it can be withdrawn at any time without reason. You don't need to give a reason. You can sign consent one day, withdraw the next. You can withdraw consent 2-3 months down the line. Your standard of care treatment, your care will not be affected by this. It's completely, the ball is completely in your court, and a decision should not be forced or pressured. It should be your own decision. confidentiality, your information during a clinical trial, your data is stored due to the data protection laws in your own country. There will be specific details of how your data is used in the patient information sheet, specific patient information sheet for the trial. Um, you'll always be kept up to date on how your data is used. So we often get sort of GDPR sort of updates from trials sponsors that we have to inform patients of. The patients then have to agree that they accept those terms and sign the consent form. So you're always kept up to date, and your personal and medical information is anonymized. So once you are um, sort of eligible for clinical trial and you've been randomized, you are given a clinical trial ID. So whenever we refer to patients to outside sources such as sponsors, medical monitors, we only ever discuss your clinical trial ID. We never discuss your name, date of birth. None of your personal information is exported outside of that hospital. Screening period. So this is a period once a patient has signed consent form, there is usually a 28-day period, and this is to ensure that you are meeting the criteria for this particular clinical trial. It ensures your suitability. It ensures you meet the safety criteria, such as ensuring that your kidney function is correct, your liver is correct, that your immune system, so for example, your neutrophils, when we check your full blood counts. And it can be a very, very busy time. There's a lot to do, depending on the clinical trial. There could be extra scans, there could be echocardiograms, which is to ensure that the heart is pumping correctly. There could be biopsies that are required for the clinical trial at baseline. With these biopsies, patients generally don't get results. They're purely for research. It's important to point that out. Some do, but the majority are purely for research, so patients don't get those results. The screening period also allows a washout period, which a lot of patients can be concerned about. But it's important to note that your doctor or your healthcare provider would not put you forward for this clinical trial if they thought that that washout period would impact your overall outcome. Um, Everything that we do is in your best interest. So if we didn't think that you had that time, we would not put you forward for this. It wouldn't be in your best interest. The washout period also allows any previous drug to exit the body, so that we're making sure that we're monitoring the effects of the correct drug, and also eradicates the chance of any drug interactions or unknown drug interactions from the experimental drug. Um, Not all patients pass the screening period. It's important to point that out also. Just because you sign a consent form, it doesn't necessarily mean that you're automatically onto the trial. You do have to pass these tests, and they're there for your safety. Monitoring. So there are many ways that we monitor during a clinical trial, and they actually can be quite intense, and the visits can become very, very frequent, especially sort of post-COVID. A lot of things in the UK, which I'm sure in the US, went sort of virtual, telephone consultations. But with clinical trials, things need to be done face to face. We need face-to-face reviews to ensure that we are recording the correct adverse events and toxicities, making sure we've got the most up-to-date and correct vital signs, weights, making sure that we are checking the right bloods at the right time, imaging. So we will look at your imaging. We'll do a baseline scan. That's usually in the screening period. And then depending on what the trial protocol dictates will depend on how often the CT scans are done. Um, Usually anywhere between 6, 8, and 12 weeks, and they can change throughout the trial as well. Obviously, we're checking your bloods to make sure that your full blood count is stable and it's safe to give the next dose of treatment. So we're looking at the hemoglobin, the white cells, the platelets, and the neutrophils, making sure that your coagulation levels are okay, that if you did bleed, your body had those reserves there to stop the bleeding, making sure that your renal function, your liver function is adequate enough to cope with the treatment as well. And one of the ways that we monitor your scans, your imaging, is through a method called response evaluation criteria in solid tumors, or it's affectionately known as RECIST 1.1. The next slide. Um, so RECIST 1.1 is a consistent and standardized monitoring method used to measure the response of cancer to treatments. It's commonly used in oncology trials and it evaluates whether treatment, how a treatment is affecting that cancer. So are those lesions staying the same? Are they shrinking? Are they getting bigger? Have they completely disappeared? And we use target lesions to track um, the progress. So the guidelines for the RECIST are in this QR code at the top there. Um, just as a kind of, I'm going to show you some examples of a mock-up patient that I've done to show how we sort of follow through the RECIST on clinical trial, but just as a bit of terminology here. So with target lesions on RECIST, we can use a maximum of 5, but no more than 2 per organ. So for example, we could have 2 liver lesions, 2 lung lesions, and 1 lymph node, but we couldn't have 3 liver lesions. There's only a maximum of 2 per organ. In order to be measurable disease as per RECIST guidelines, a cancer lesion has to be at least 10 millimeters in its longest diameter, or if it's a lymph node, it needs to be equal to or greater than 15 millimeters in the short axis. Some of the terms that we use or that you will hear when we are giving scan results would be stable disease, progressive disease, partial response, and complete response. So there's a visual aid on the next slide for people that sort of find this difficult to understand when it's just a sort of a load of words on a page. But stable disease essentially is a minus 29, anywhere between minus 29% reduction to a plus 19 increase from that baseline sum slash nadir. Progressive disease is equal to or greater than a increase from 20% increase from baseline or nadir. A partial response is a reduction greater than 30% up to 99% from the baseline slash nadir. And a complete response is no visible cancer on any imaging. And it's important to note that that just means radiologically. It doesn't mean that the cancer has disappeared. There could be microscopic disease, but radiologically it's disappeared. And just as a explanation, the nadir is the smallest sum of diameters that has occurred on treatment. I'm hoping the next couple of slides will explain a little bit better. So I've kind of mocked this up to try and help. So I'm just trying to move my thing here. So if we look at the baseline, so this baseline in the middle could be any sum. So for example, we could have a total, let's make it easy and let's do the total sum is 100. If we, on the first scan, we have a reduction of minus 22%, you can see that we would still be in the orange because we've not yet reached the 30. So that is still classed as stable disease. If on the next scan, we then went to minus 32, you can see that we cross over into the green section, which would be partial response. But if we go back to the baseline and we use our baseline as 100, and then the next scan we have our total sum to be 133, and we would cross over into the red, and that would be classed as progressive disease. Any new lesion at any point throughout trial would be classed as progressive disease, and that's despite any response to any of the tracker target lesions. So this is an example. I hope this makes sense. There's 4 different slides to go through. So if we look at the red box, we can see that this is the baseline scan, and we're tracking 2 liver lesions and 1 lymph node. So because we've got a liver lesion, we're going to use 2 liver lesions, we're going to use the largest sum, the diameters, which is 32 plus 21, and then the lymph node, we're going to use the short axis. So 32 plus 21 plus 17 comes to a total sum of 70. So this is our baseline figure that we're going to work from. The scans on this particular clinical trial are 8 weeks. So if we go to the first on-trial scan, you can see that we've actually had some reduction. So we've gone from 32 to 27 to 22 and to 15. So the total sum there is 64. So we work that out to be a -8.6 decrease, which would be classed as stable disease. This 64 sum, because it is the lowest so far, will become the new nadir. And this is the one that we will work from going forward. So now if we look at the second on-trial scan, you can see that the numbers have increased. So we've gone to 31 in the longest diameter, 25, and then 16 on the shortest diameter for the lymph node, which adds up to a total of 72. And we're working from the 64. And this is a plus 12.5%, which is still stable disease. It's still within that from baseline -29 to plus 19%. And then visit 3, we unfortunately have quite quite a lot of enlargement. We've gone to 38, 29 and 19. The total sum comes to 86, and this is a plus 34% from the new nadir, which is the 64. So this is classed as progressive disease. When we talk about monitoring your side effects or your toxicities, your adverse events, we use something called the CTCAE guide. And if you scan the QR code in the top, you can access this guide, or you can search it on Google. And the tool was designed to standardize the reporting of adverse events in oncology, and it was first used in research. It contains global definitions of adverse events, which enables clinicians to report adverse events more accurately. And we use a grading system. So every adverse event will have a definition, a grade, and an explanation of what that grade is. And based on the grade that we assess that toxicity to be, will determine the action that we take. So most clinical trial protocols will say, for example, grade 1 diarrhea, increase fluid intake, introduce Imodium, a drug that will help with diarrhea. Grade 2, you may require a dose reduction or maybe a week's deferral of treatment. It all depends on what that clinical trial protocol says. There are different ways that you can find clinical trials. So the main place that you can go to find clinical trials will be clinicaltrials.gov. You can search this, you can search by disease group, treatments. There's different ways that you can search. And then obviously we have the Cholangiocarcinoma Foundation. There's a great clinical trial section on the website. There's videos on there. They also have kind of built-in links that will take you through to the clinicaltrials.gov website. And I guess it's important to say that clinical trials open and close quite regularly. So at every time point that you're needing to change treatment, stop treatment, it's always worth checking because they open and close regularly. And if there may not be one when you need in first line treatment, but there may be one when you need second line treatment. There's a list of useful resources on the page there. You've probably seen the new myth versus fact info sheet that was circulated last week from the foundation, which I think is very, very useful and can answer a lot of the common misconceptions also. So I've put a QR code on there which will take you straight to that. But then there's also a list of websites for further reading. So, in summary, the primary goal of clinical trials is to ensure that new treatments are safe, effective, and beneficial. They are conducted using a standardized set of tools and guidelines, approved by the relevant ethics committee to ensure that what we're doing is ethical and in the best interest of the patient. They are needed so that we can find new ways to prevent, detect, and treat cancers, and they provide opportunity to access new treatments. And of course, we do it for patients. We want to improve the outcomes and the quality of life of all our patients. So thank you to anybody who's ever taken part in research and caregivers. Um, we need patients and caregivers to continue taking part in research so that we can continue to improve the quality of life and outcomes of patients with cholangiocarcinoma. So I encourage you all, if you get the opportunity, to please take part because we need you. And then there's just a couple of slides at the end. I'd just like to know if you feel a bit more confident, a bit more informed. Hopefully you do, but please be honest. But you've all put your phones away. Okay, well, there's definitely more down the right-hand side, which makes me happy. Even if you just moved up one, that's good for me. You know, I've hopefully helped you. Um, Thank you for listening. Questions are welcomed. And just while we're going through questions, I'd appreciate this is the first webinar that I've ever done. It's the first presentation to patients, so I'd be grateful of any feedback if you could please provide that. You can either visit the website or scan the QR code and just give some honest feedback so that I can take that feedback forward and hopefully improve. But I guess over to you guys and the questions.
Thank you, Dean, and thank you everyone for tuning in. If you do have any questions, please add them to the chat or the Q&A. There are two questions that have come in so far. Can the slide deck be available to the patients, Dean? Is that okay if we were to include that?
I can certainly, yeah, I can circulate them to you. Yeah.
Perfect. And then if a trial is a phase 2 trial and you're on a waiting list at one site, does it basically include all the sites, or do you have to register with each site separately?
I'm not sure how it works in the USA. So in the UK, we can refer patients on to different hospitals within the NHS. We don't really have waiting lists in the UK like that. So I wouldn't be able to answer for the US patients. Sorry.
No, that's okay. Um, are there any unique clinical trials at the Christie that are also being performed for cholangiocarcinoma in the US? Do you know of any?
Question. I don't think any of them are being done in the US that I'm aware of. We have one currently looking at the biomarkers in the saliva and the stool.
Uh, this is Fred. Manchester United or City?
Actually, neither. I'm actually Liverpool.
I know that we get questions a lot from patients in terms of like, and I don't know if it's different in the UK, but if you are, you mentioned that you're not technically enrolled in the study until you pass all the screening. So could a patient sign multiple informed consents for different trials as they're trying to see which one they would be accepted into? Do you have a question, an answer to that?
Well, I guess in theory, yes. However, as soon as a patient sort of receives treatment, that usually makes them ineligible for other clinical trials because they've then received treatment for that line of treatment. So I guess in theory, yes. I guess if they want to save time, they can sign up to multiple trials and see which one that they um, are eligible for. I wouldn't encourage it, I don't think. Um, it makes things very confusing mainly for the patients, to be honest, and we can then get a little stuck in what to do.
Mhm. Okay. Um, do you have any suggestions on how to find out the tests, the costs that are paid for by the trial and those which are considered standard of care?
So again, in I'm unsure in the US, in the UK, treatment is given on the NHS, so the patient doesn't pay for anything. Um, some clinical trial sponsors, usually the commercial studies, pay for all the tests within that clinical trial. They pay for the bloods, for the scans, for the drug, and they also sometimes pay patient expenses. Um, Again, with it working a little different in the US, I wouldn't be able to say as to whether what they do and don't pay for. But usually, if it's commercial study, they will pay for everything during that study that the patient requires per protocol.
Okay. For this individual, I think in the US it's more of an insurance related question. So finding out from the insurance company might be another way of trying to figure that out.
Yeah, that's a good way of finding that out. Yeah, check with the insurance company.
I don't see any other questions that have come through. If anyone has any other, oh, is there is there any leeway on patient selection? For example, higher than typical creatinine but stable for 5 years?
If you repeat that question again with regards to
Is
the
there
creatinine.
is there any leeway on the patient selection? So, for example, a higher than typical creatinine but stable, but the patient's been stable for 5 years. So, would that be like a leeway in
But there
accepting?
is usually a set criteria that patients need to meet, and again, that's down to safety. Um, if that is something that you know, the treating doctor is happy with, that it's stable and they feel that the patient could tolerate treatment, then the clinician could always contact the medical monitor and discuss that. We've done things like that in the past and had waivers, but waivers aren't usually allowed. It's down to the discretion of the medical monitor.
Um, so if someone is doing well in their current treatment, should they try a trial, or are trials only for people who are not on any treatment?
So usually with clinical trials, if you are on current treatment and you're doing well, firstly, we wouldn't want to stop that treatment anyway because we know that you're doing well. But also, you probably wouldn't be eligible because usually, for example, if they're on treatment, then the study is probably going to be a second line treatment. And usually in second line studies, you have to have one of the eligibility criteria is you have to have progressed on first line treatment. So if you're going well on treatment, then you wouldn't meet that eligibility criteria. And I wouldn't encourage stopping treatment that you're doing well on.
Okay, perfect. No other questions have come through. So thank you, Dean, so much for your presentation.
Thank you.
Um, and we will make sure to get your slides and put them with the recording of this webinar so folks can have access to that. So thank you
Thank you very
everyone
much.
for being here today.
Thank you. Bye.